virtual diet,
Good
and
morning.
our co-chairperson, Dr. D. Ramamurthy. And now I would like to hand over the virtual dais. Yes, Dr. Ramamurthy has just joined in, bang on time. Good morning, Dr. Ramamurthy. Namaste, welcome. Sir, you need to unmute your mic, sir. You're not audible.
Very good morning to all of you.
It's good to see you, sir. So our co-chairperson, Dr. D. Ramamurthy, has also joined us. And now I would like to hand over the virtual dais to our chairperson, Dr. Mahipal Sachdev. The dais is all yours. Thank you, sir.
Yeah, thank you very much, and welcome to this particular session on advances in cataract surgery. I have with me Dr. D. Ramamurthy, who we all know has been the past president, past chairman, scientific committee of All India Ophthalmological Society. He is a renowned cataract and refractive surgery and also trained in vitreoretina. And he's excellent as regards telling us about details about what is new. He specializes in various types of intraocular lenses and has a wide array of knowledge as regards the premium IOLs. He's going to be co-chairing the session with me, and I have a young upcoming ophthalmologist, Sartaj, who's been trained out of All India Institute of Medical Sciences, RP Center. Actually, all three of us are from RP Center. And he's going to be also talking about what is new as regards the intraocular lenses and how we are redefining monofocal vision. So let us, without much ado, there is enough time for all these speakers. So 15 to 20 minutes of talk, and then we can have about 10 minutes discussion on that. Dr. Ram, would you want to say something to start with, or we can start?
I think you said it all. We can start, apart from saying that it's nice to have Mahipal as the chairman. I mean, I don't think he needs any introduction, whether as an entrepreneur, as an ophthalmologist, as a teacher. And of course, Sartaj is there completing the morning, the young generation. Over to you, Sartaj.
Yeah. Thank you, sir. I'll just share my screen. Okay, so I hope my screen is visible.
Yeah, you can proceed. Yeah.
So good morning, everyone. I would like to thank AIOS and Johnson & Johnson for giving me this opportunity today. So I'd like to share my experience with this new monofocal IOL that is available, the iHands by Johnson & Johnson. This allows us to improve spectacle independence for our patients who are undergoing cataract surgery. So our visual requirements today are very different from what they were only a few decades ago. Far more activities today are dependent on intermediate or even near vision. So spectacle independent vision for distance after cataract surgery is just taken for granted. Everybody expects that. But now more and more patients are demanding adequate intermediate and near vision without glasses after surgery. Now, many tasks which require intermediate vision in our daily life can be activities such as cooking, driving a car so that you can see the dashboard on the car, if you are into playing any kind of musical instruments as hobbies are picking up, and most importantly, all of us who spend a lot of time on computer screens. Now, with the pandemic over the last 2 years taking more and more of our life and our activities online, this desire for better spectacle independent near and intermediate vision is greater than ever. Now, there are numerous premium presbyopia correcting options that are available, which we can offer to our patients, but most of them come with different limitations. Most significant being the photic phenomena that can lead to dissatisfied patients. And also these IOLs have a long list of relative contraindications. They also carry a significant premium in terms of cost, which not all patients would be able to afford. Now, preoperative counseling for these patients becomes a very tedious process because you are explaining the possibility of photic phenomena, and it's very crucial to explain that preoperatively, but it also makes patients very hesitant. Monovision, on the other hand, is a good option for a small proportion of patients because the loss of binocularity means that they would still need to use correction in certain situations requiring good stereopsis, such as if you're driving on the highway over a long time. Now, what if you could provide something better to your risk-averse patients? So a newer generation of enhanced monofocal IOLs claims to provide improved intermediate vision by simply increasing the asphericity of the interior surface of the lens. So on gross examination, the eye-hands appears like any other monofocal IOL. The process of loading, injecting the IOL, even the biometry and IOL power calculation is the same as with a standard monofocal IOL. So it eliminates the need for any kind of learning curve. Preclinical trials have also shown that the lens has the same tolerance to decentration as any other monofocal IOL, meaning even for younger, relatively newer surgeons, it is a good tool. And again, we can see that even on a red glow, it appears no different from a monofocal IOL. So Dr. Tonieto et al. Used surface profilrometry to determine the superficial profile of the eye-hands IOL and compared it with other standard monofocal IOLs, including the Technis 1. So in this figure from this study, we can see the profiles of two standard monofocal IOLs compared with the eye-hands IOL. No obvious difference can be appreciated in the line representation of the eye-hands and the Technis 1. However, after removal of the best fit circle from the raw profiles, the differences in the interior surface become appreciable. Now, as expected, the standard monofocal IOL showed flat subtraction lines, meaning that in the central 2.5 millimeters, the profile of the IOL was perfectly circular. Now, the higher order sphericity of the interior surface of the eye-hands is visible because it's visible as a progressive, smooth altitudinal change of only around 4 microns in the central 1 millimeter of the lens. So what about my experience with the eye-hands? Now, I've been implanting this lens since September 2019. And rather than position this lens as a premium alternative to any other aspheric lens, we have moved entirely from the Technis 1 to eye-hands. In my perspective, it simplifies the preoperative counseling and the IOL selection from the patient's perspective. So in our data of 116 consecutive eyes, of which 71 were implanted with the eye-hands, we can see on the plotted defocus curve that the eye-hands matches the Technis 1 at distance and then maintains an edge above the Technis 1 for the entire range from intermediate till near. Now, the eye-hands provides better uncorrected intermediate vision and near visual acuity, and the difference was statistically significant. Dr. Minucci's publication reported a better intermediate visual acuity in patients with bilateral IC2 versus the Technis 1. They observed no statistical difference in contrast sensitivity between the two groups. And their binocular defocus curve was similar to the one we also published, in which the eye-hands achieved a smoother profile along the entire curve and showed significantly better defocus curves at simulated intermediate vision between -1 and -1.5 diopters of defocus. Now, this is a questionnaire used by Poyelis et al. To help assess the quality of vision after implantation of extended depth of focus IOLs. We deployed it in our practice to help us analyze the quality of vision in patients implanted with the eye-hands IOL. Now, results from the questionnaire showed slightly better scores with the eye-hands across majority of the different questions, particularly when asked about satisfaction with near and intermediate vision. However, on the questions on night driving and just general vision during the daytime, the Technis 1 did edge out over the eye-hands. Now, in Dr. Minucci's study, the patients were administered the patient-reported spectacle independence questionnaire, and only 20% of patients in the eye-hands group reported the need for intermediate correction in their everyday life, whereas 90% of the Technis 1 group required glasses for everyday intermediate vision tasks. So what are the advantages? So now, unlike multifocal or EDOF lenses, there are no restrictions in patient selection. It can be implanted in patients who have a normal monofocal in the other eye. If you implanted both the eyes, you have the advantage of binocular summation versus if you were looking at monovision in the same, even micro monovision. It has the same A constant as the Technis 1, so transition for power calculation is absolutely seamless. It simplifies preoperative counseling and IOL selection for a patient. What are the limitations as of now? The major one is that there is no toric correction available in our country as of yet, but is expected very soon. The other challenge can be setting appropriate expectations for your patients. When you try to explain that this gives you better intermediate vision, but not necessarily better near vision, it is important to use maybe a few examples and illustrate that, because many patients will tend to be unsatisfied with the near vision. They assume that this is a lens that is correcting near vision also, but it is important to clarify that to the patient. So the takeaways are that this is a lens that can potentially redefine the standard of care for visual rehabilitation after cataract surgery. It is not something that is groundbreaking. It's not something necessarily that is entirely new. It's more like a transition from, if you go from an iPhone 10 to an iPhone 10s, it's not an iPhone 10 to an iPhone 11, which is something completely new, a completely new generation. It's a gradual progress, but it actually can have a very profound impact on our surgical results over a larger scale. It does provide improved independence from glasses for many daily tasks for our risk-averse patients. Thank you.
Thank you, Sartaj. Yes, I agree with your summing up of the whole thing. But obviously, there's a large enough number of patients who still do not want to go in for the presbyopia correcting lenses. And I personally feel that there have been significant improvements in the trifocal lenses that have come. So once we reach a stage where the photopic phenomena are almost eliminated in those particular cases, maybe these would be not the go-to lenses as things stand. The non-availability of the toric lens is obviously another one, as in when you're looking at these lenses, the toricity is today corrected even for smaller degrees. My only thought is that how you position this preoperatively to the patient. Do you tell them that you are giving them something different from the normal monofocal lenses? Do you kind of hesitate at all, if at all you do, in patients who have had a pseudophakia in the other eye with a conventional monofocal lens? So pre-op counseling to the patient, and any hesitation in implanting the other eye with an eye hands, even if you have a monofocal in the other eye.
This is a very good question, sir. So as far as preoperative counseling is concerned, yes, we do try and explain the advantage of this particular IOL in terms of intermediate vision. And it's actually made it easier when you're trying to convince patients to go in for a premium aspheric IOL. Earlier, it was very difficult to explain just the advantages of an aspheric IOL, or what an aspheric IOL is in itself, to a patient. But when you can give them a description that is something that they can relate to, that yes, your intermediate vision will be a little better, it does help convert patients to at least a premium aspheric IOL. We have almost eliminated any other aspheric monofocal IOL in our practice. So from that perspective, we don't want to compare it to that. But we do explain the advantage of intermediate vision. As far as patients who already have, let's say, a Technis 1 or any other aspheric IOL in the other eye, since we have priced it at the same point, if it's just a patient coming for second eye surgery, we actually will not really talk about much. But even in those patients, many of them do end up appreciating the slight difference in near vision. Usually, if with the Technis 1, the patient is using a near ad of about 2.5 diopters, we will see anything between 1.75 to 2 diopters near ad for this eye. So that does lead to an appreciable difference. But the best part is, there's no downside. You don't have to explain that, this could be one limitation. For most patients, if you could, it could pass up as a routine monofocal IOL.
So is there any degradation in the MTF?
The studies that have been published, yes, compared to the Technis 1, there is a marginal degradation in the MTF. In fact, the directions for use booklet that used to come with this lens, particularly in the North American market, used to actually carry 2 disclaimers. One was that in the preclinical trials, no clinically significant improvement in intermediate vision. But the subsequent studies that have been published have shown that there is an improvement in intermediate vision. But yes, the MTF curves that were published by the company themselves also showed that it is marginally lower than what it is with the Technis 1. But again, in the studies that have been published for distance acuity, it matches what we get with the Technis 1. So it's fortunately not very perceivable.
Ram, any thoughts, any comments?
Great presentation, Sartaj. I think nice to know that you have shifted almost completely to it. And just a question, have you tried micro monovision with these lenses? It's giving you a little bit of intermediate vision. And just the fellow eye, if you aim at a -0.5, -0.75, So bilaterally implanted, these patients are a little more comfortable. Have you tried that?
Yes, sir. So I feel, results for what we look at results and what a patient considers results can vary. You have to be a little careful because sometimes patients, they immediately tend to compare and for whatever reason, first post-op day is still them looking at the Snellen chart and being like, oh, I can read 6.6 with this eye, but I'm having a little bit of difficulty with this eye. And they become suspicious. If you feel that, yes, this is a patient who can understand what we are trying to achieve for them, micromonovision is the way to go. Usually, what I would do is if I've hit a little bit of hypermetropia, then definitely I will try to hit a little bit of myopia with the other eye.
So Ram, what is the penetration as regards the eye hands in your practice or in your center?
Basically, it's not very high. We either go for monofocals or multifocals because we have a distinct group of patients who do not want multifocality. Anybody who's looking for a true multifocality, then it's either Synergy or the current crop of trifocals, which really gives them distance, near vision, etc. And of course, with these current lenses, we find that it's not that the dysphotopsia is not there, but it's significantly less than the earlier multifocals that we used to have. So essentially, we would use these cases in patients who have multifocal, who are interested in multifocality, but you need to counsel them about dysphotopsia, glare, for whom night driving is a lot, but at the same time, they're interested in some amount of intermediate vision. Active people who are in their 50s and early 60s, maybe, we go ahead and use these lenses. Again, as Sartaj said, there's really no contraindication to this lens. Whenever you can use a monofocal lens, you can go ahead and use these eye-hands lenses. So whether it's a early ARMD with dry ARMD with some drusen, glaucoma patients, and patients in whom you will be, because the drop in contrast sensitivity that occurs with multifocality, and even patients post-refractive surgery. So these are the cases where we would go ahead and where the patient is interested in some kind of a add-on, something more than a monofocal intraocular lens, but at the same time is somewhat averse to the idea of a multifocality or not fit for a multifocal lens. We go ahead and implant these lenses. And I think that one of the best things, though this is a scientific session, but we cannot move away from it. One of the best things that Johnson & Johnson has done is to price this lens right. In case, it had been priced at double the cost of a monofocal or 2.5 times the cost, obviously the penetration would have been very less. Because it's just a couple of ₹1,000 more. Whenever you have to upgrade these patients, as I know that, as Sartaj mentioned, there are several practices who have virtually given up their Technis monofocals and shifted on to this, where you give something more to a patient at a very reasonable cost. It's just an add-on advantage that this lens offers.
So I would echo the sentiments, as you said, regarding a lot of practices having moved on, and that's what Sartaj is also saying. Our doctors at Center for Sight have actually lapped up this lens pretty significantly, and the penetration of the routine monofocal has gone down, and there isn't a lot of counseling that is done for the patient as to what to expect as being something more than the other. Because as you rightly said, the price points are pretty much similar. There is about a few ₹1,000 more. Obviously, the hospital is not, the cost of goods is going up as a percentage, but we are not saving anything. It goes to the company. But I think in any case, they have done a sensible thing, because I personally, if I foresee, until of course we have a very good trifocal where these photopic phenomena go, this could become the standard of care. And once you have the toric version also, this could become a standard of care instead of the monofocal lenses, because you have the solid Technis platform, which we have all tried and seen. The biggest advantage being the square edge that you have, the material that you have, the lack of glistenings, which is very, very important. I have yet to see glistening coming in a Technis 1 lens, though they have not advertised it as a glistening free lens as Invista has, but that is definitely the advantage, that you have a dependable, the inserter system being pretty good. So you have a dependable platform on which you are working. The icing on the cake would have been possibly if they add the achromaticity also in these, because that again should be a standard of care. Like an asphericity has become a standard of care. I think an achromaticity should also become a standard of care. So maybe the quality of the vision could improve further if you have what maybe one can say an IHENS plus or something like that, if you have an achromaticity also on top of that. So all in all, at least even in my practice, I write an IHENS without giving it a second thought for a patient. So whether the patient has had a monofocal in the other eye or not. And I don't even discuss the cost difference, because there are equivalent other lenses in the monofocal arena which are approximately the same price. So a lot of significant cannibalization has happened, and I have not had a dissatisfied patient with an eye hands because of the lens so far. As I have said before, I have implanted it in ophthalmologists, I have implanted it in cardiologist, invasive cardiologist, and things like that. And people have high bureaucrats, ministers, so they're pretty much happy with this particular lens. And it has substantially taken. There is so much of demand, I would say, of the eye hands, that there is a shortage of supply at times where we don't get powers of the eye hands that is there. So all in all, I think J&J has done a wise thing to position it at a price point where it is cannibalizing the monofocal lens practice. Any other point anybody wants to? Yeah.
I think I echo your thoughts as far as achromatism is concerned. Now we have understood compensation of spherical aberration. I think going forward, and especially since J&J already has its technology, I think they must go ahead and they have a material with the highest Rabi number, which has the inherent ability to reduce the chromatic aberration. They should also incorporate this technology, not just in eye hands, but also in the thickness monofocals. And another query that I have is that, almost, eye hands came first, and subsequently, that's again a good lens, Vivity. I find that both these lenses have somewhat similar properties, though optically they work on different principles, where they are not really multifocals, but they offer something more than monofocals. Sartaj, Maipal, you have any experience with those lenses, and what's your take on the performance?
I would refrain from commenting because I have not implanted a single VVT. So I really don't have any practical experience because they didn't give me any lenses to try. And the only thing which puts me off is the price point of VVT, because as I have heard other people, including you, say that it is almost similar to the eye hands or maybe a little better as regards intermediate vision. But the price points make it a lot different, because if you're charging more than a trifocal lens, I don't think the patient is going to be satisfied. So I don't know from a satisfaction perspective as to what it is, because dysphotopsias, photopic phenomena has gone down significantly in the what you will be talking about, the CRV lenses, etc. So I will refrain from commenting on the results of VVT because I don't have any first-hand experience. Sartaj, maybe if you have any.
No, sir, I will echo exactly what you said. The company refused to give me also any lenses. So no personal experience, but you're absolutely right. It's the price itself just makes it apples versus oranges, because Dr. Ramurthy once earlier mentioned that, with the eye hands, you're getting peanuts for peanuts. And I think that was perfect, that you don't have to think about it. With the Vivity at that cost, comparing it to trifocals or even more than trifocals, the patient's expectations also disproportionately go up. So that lens, again, I've no personal experience, but yes, what I've also heard is not astounding results. So let's see, time will tell.
So Ram, there is also another thing that majority of my patients, I would say almost all, or maybe more than 90-95% who go in for a premium lens also go in for a femto. So actually there's a double escalation for them. So they would end up, if you're doing a VVT at that, to be paying about 1.5 lakhs. So that and the insurance doesn't cover that. So they are out of pocket by over ₹1 lakh. So that becomes a bit more challenging. That's what I feel that if you have, but obviously we do have such patients. Maybe you could share your experiences on the VVT, because both of us are pretty much empty on any experience as regards VVT?
We have done a few VVT lenses. We're one of the first ones to do, and then subsequently we are also doing it occasionally commercially now. Again, the issue with that lens is neither a true multifocal nor just a monofocal. It offers something more, just like the high-hands. And for genuine reading, you need to wear +1, 1.25. I personally believe that it offers a little more than the high-hands as far as the add power is concerned, but not a lot more. So essentially, I would consider, though optically the two lenses work slightly differently, what they offer is somewhat similar. And what sets us apart and why high-hands has been taken up so well and VVT is slightly lagging behind, though there are quite a few adherents to it, is because the price that we pay for it. Essentially, it's easy to convert a patient from monofocal to high-hands, but telling a patient that you pay almost a little more than a high-quality trifocal or synergy, and you still have to wear reading glasses is somewhat a little difficult. And I think that's why, even my initial comment was that, one of the best things J&J has done is how they are commercially positioned high-hands.
So Ram, there is also a problem of, I would say, communication that you get, because when you are positioning for trifocal, I would say, and you're positioning for this, you have to actually undersell or bad sell or badmouth the trifocal as regards the photopic phenomena. And you have to dissuade the patient from going in for a trifocal lens and yet paying for an equivalent of a trifocal lens, because you say that there's a lot of photopic phenomena and things like that. So there's a confusion with the counselor will have. The patient will obviously have a confusion as to what exactly to sell or what does not. So actually, I don't sell or I don't even talk a patient into high-hands. It's a given now that we do it. So that's I would say that's the kind of split messaging that would come, that obviously if you have to push a patient to VVT and not give him readers and still give him readers, that becomes a little problem. Okay.
One last question, Sataj. I mean, since you have seen the optical profile and obviously you looked at it into greater detail, do you think there is a possibility going forward for the high-hands to be increased in its capability by increasing the central 1 millimeter of curvature, or increasing the size of where they bring in the variation so that it offers a little more optically? Do you think it's possible?
It should be possible, but I'm sure that, the 4-micron difference that they have come to must have been after some clinical trials, because again, the advantage of the lens right now is that whatever that difference or loss you get in the MTF, it's not clinically experienced by the patient. So now, what are we going to have, like sort of diminishing returns by increasing it and more sort of adverse effects? I guess, I think what Dr. Maipal said and what you also echoed, achromicity will probably be a better thing to incorporate rather than maybe changing the sphericity further.
So I think, Ram, this is the sweet spot that has been found out on the bench studies. And that is what it is. So in case we need to get a nearer add to increase, I think it is going to take away something. So I think this is the sweet spot. But obviously you can, as you rightly said, monovision, mini monovision, etc. is something that works very, very well in an high-hands. Okay, let's move on to the next topic on the IOL technology. And that is on the continuous range of vision, and that continuous range of vision at a difference, and that is what Ram has put it as life begins at 33 centimeters. So over to Dr. Ramamurthy, please.
Can you see my slides?
Yeah, perfect.
Okay. So as a follow-up of Shataj's wonderful talk on this modified monofocal, let's go on to the high-end multifocal intraocular lens where now we have access to. I'm going to be talking about the Synergy intraocular lens. By way of financial disclosure, I'm a consultant to both, relevant to this talk, I'm a consultant to both Johnson & Johnson and Alcon. I think I have always found that whenever we prescribe a pair of spectacles, whether it's to a 10-year-old getting his first myopic glasses or a 42-year-old being given his reading glasses, or a 60-year-old who has just received a simple hydrophilic intraocular lens, do you say you have to go ahead and wear glasses? There is a tinge of dissatisfaction. So if only we could address all these patients across all age groups to live independently without the relying on glasses, that would be a great way to go. And I think as surgeons of the third millennium, we owe it to our patients and ourselves to find ways and means of doing it. So my pal, myself, and several others, obviously Sartaj is a new entrant, have been talking about multifocals, have been using multifocals for a couple of decades. But then I think even today, our penetration as far as multifocals is concerned is just about 15%. And the torics being adapted more frequently. It's the cost is, of course, the concern, but then it's not just that. There is definitely a certain segment of population who want the very best, irrespective of the cost angle. And one of the things is often we have to make the patient pick and choose as to what they want. It's whether you want near vision to be good or intermediate or distance. Obviously, the other aspect is also life happens at all kinds of lighting conditions, bright light, dim light, ability to drive in the night without much of discomfort. When you tell the patient that your intermediate vision might be a little less, but you would be able to read quite well, you would be able to see at distance and reading, but obviously there might be glare and halos that you have to contend with. These are some things that you can tends to put the patient off and make them stick to a monofocal option. So obviously, if you had a lens which could take care of the visual needs for all distances at distance, intermediate and near, that would be a great way to go. Another important factor is that the arm span of the patients, when we talk about near vision being at 40 centimeters or at 60 centimeters, intermediate vision being at 60 centimeters, that's not quite adequate. When we talk about most of the trifocals that are currently available, most often they are talking about near vision at 40 centimeters. But especially in our conditions where the people are built somewhat smaller in the Asia Pacific region, and the arm span is less, and 5.5 feet is the normal height of the individual, as well as the kind of calligraphy that we have, the kind of the Chinese letters as well as the Indian letters are obviously much more closer than the English language letters, the alphabets. So obviously the kind of near visual acuity that our patients need is much higher. And on a lens which offers them an ability to read well at 33 centimeters rather than 40 centimeters would be a great choice. I always considered is the paradox of the premium when we talk about premium intraocular lenses. I have been doing this for the last 15 to 20 years. When I go to a great restaurant and I want a wonderful meal to be enjoyed with my friends or family, what I'm looking for is a well-rounded experience. But if the chef walks up to me and says, "Sir, I'll give you a premium meal, but your soup might have a little extra salt. Your main course might be a little undercooked. Your sweet dish might be a little too sweet." Obviously, I'm going to ask, why are you charging me a bomb if there's going to be such compromises? I think we have been doing exactly that to our patients. We have been charging them significantly more for their multifocals or multifocal torics. But at the same time, compared to monofocals, which is a no-brainer, and both we and our counselors tell them you can straight away go for this lens, it would give you a good vision. We spend a considerable amount of chat time trying to explain to them and trying to make them accept and understand the kind of demerits that these lenses come with. So obviously it's a paradox of the premium, and if we going forward we have to adapt this in our highest numbers, we have to do away with this. As was said earlier, monofocal intraocular lenses are great lenses. And I think that's something which should give you excellent vision. It's a no-fuss lens giving excellent vision for distance. But obviously for intermediate and near, the patient might need a more progressive lenses outside. Then multifocal intraocular lenses, which you have been using for quite some time, it gives you a good distance vision, good near vision, but there is a significant segment which is where the intermediate vision, where it's not quite adequate. And basically, as we know that more than near vision in our day-to-day life, intermediate vision is becoming more important. Is not looking at the tablets or looking at the laptops alone, that's important. But it's also even for doing your shopping, doing your driving, when you have to look at the dials of your car, and even at cooking or sewing and threading. All these things, intermediate vision becomes quite important. So all kinds of patients, obviously, multifocal intraocular lenses come with a caveat that there might be an inadequate intermediate vision. Then we have the trifocal intraocular lenses. I believe most of us who are doing premium lenses are using these lenses, and I have a significant experience with them. And overall, it has been a great lens. But at the same time, there again, there are areas where the lens seems to be quite inadequate, especially when it comes to near vision at the distance of about 33 centimeters or so, where it seems to be quite inadequate. And something like a synergy, where you have a continuous range of vision, that's synonymous with synergy, where obviously there is a little drop off in between, but overall, right from infinity all the way to 33 centimeters, you have a reasonably good vision. That might be a good way to go. How does this, what exactly is the origin of the name synergy? It's because of a synthesis of the advantages of a true multifocal lens like the +4 ad Technis multifocal and the EDOF lenses, which occupied our practice almost for a couple of years in the period between 2017 and 19, before the trifocals came in. So essentially, one of the first multifocal lenses I was seriously using were the Technis +4 diopter lenses. And especially even today, if I have a 80-year-old who doesn't drive much, who doesn't go out much, but wants to look at the newspaper without relying on glasses, wants to have good distance visual acuity, it's a great lens. But the only problem is that the near vision is 25 centimeters. And of course, subsequently, the low ad multifocals came in with a 2.75 ad and the 3.25 ad. You can mix and match these lenses or do a micro monovision, as we already discussed, to achieve the kind of visual acuity that these patients want once they are bilaterally implanted. The Symphony was a great lens. Basically, it gave us a good intermediate vision, but when it came to near vision, there was a drop-off. The Synergy is a lens which seems to synthesize the advantages of both the Symphony and the excellent near vision acuity that the true multifocal intraocular lenses offered, so that there is a continuous range of vision that these lenses offer. So as you can see here, you have the true diffractive multifocal lens here, the EDOF lens over here, and the combination of these two is essentially what the Synergy offers. Basically, the EDOF lens or the Symphony used to offer the HLA design of these lenses used to work very well for intermediate vision and for distance vision. In the case of Synergy, what this HLA design did for the intermediate vision is doing for the near vision, so that we are having a continuous range of vision from near to distance. Looking at the defocus curves, most of you would have seen these curves earlier also. What you see over here in the green might be what's ideal, where you have a logMA visual acuity of 0 or better for distance. And when it comes to intermediate and near, you have it all the way in the region of 2020 or 2025, even when with a +3 ad, that is when the near vision is 33 centimeters. What we see with our conventional multifocal intraocular lenses is an excellent distance visual acuity and a reasonable, very good near visual acuity, but there is a significant drop over here where the intermediate vision is absent. And basically, this peak over here would essentially depend upon what is the ad power that is there in these lenses, whether if it's a 4 diopters, it will be at 2.25 centimeters. If it has 3 diopters, it's at 33 centimeters. But then there is a significant area where the visual acuity is not good. Symphony, as I said, was a great lens. Again, it offered up to intermediate vision, up to about 60 centimeters. It offered good visual acuity, but subsequently there was a significant drop off, so that you had to mix and match or do a micro monovision with these lenses. What you get with the Synergy is something like this, where you have a peak for distance and all the way across right up to near visual acuity at 33 centimeters. You have a vision between 2020 and 2025. And that's the reason that the adaptability, the take of these lenses happens quite easily. We have done about an analysis of 64 eyes. We have implanted a lot more in recent times. And what we find is the mean defocus curve of these lenses is an excellent right up to from infinity, almost up to 33 centimeters. These patients seem to be able to give excellent visual acuity. The conversation on mini monovision, micro monovision, mix and match has almost disappeared today. We go ahead and implant lenses aiming at emmetropia in the first eye, never do a bilateral implantation, and then watch for the outcome in the eye, and go ahead, and we find that most often with the synergy, we are able to implant to emmetropia. So that bilaterally implanted also, these patients work quite well. As I already mentioned, the Technis Synergy lens essentially has a proprietary diffractive design of the Synergy lens with a peak for distance and continuously distributed from distance to near. There's no areas, no lacunae from near to distance, and that's the reason that this proprietary SLA design is enabling these patients to see continuously all the way from near to distance. In the case of the Symphony, which preceded this was from intermediate to distance, but here you have all the way from near to distance. So this is again another representation of the same features: monofocal intraocular lens, precise focus for the far point. In the case of a multifocal lens, good vision for intermediate, but good vision for near and distance, but intermediate was somewhat deficient. In a case of a Technis Synergy, right from near to distance, you have a continuous vision that's available to these patients. The other important factors today, we all realize that it's not just the quantity of vision that's important, but the quality of vision is also extremely important. And MTF, for the modulation transfer function, is nothing but the comparison between the ratio of sharpness of the image. I'm putting it in a very simple words: the sharpness of the image of the object to the image of the image that's formed with the optical system. Any optical system, whether it's a natural eye or a camera lens or an intraocular lens, is going to cause a certain amount of degradation in the quality of the image compared to the quality of the object by means of contrast sensitivity. And what you find here is that Technis Synergy in photopic conditions performs slightly better than the other lenses, the other trifocal lenses that are commonly in use. But in scotopic conditions, when the pupils are dilated in a 5 millimeter pupil, the contrast sensitivity that you get with these lenses, the MTF, is almost twice as compared to the conventional multifocal, the trifocal lenses that are in use today. This is another important slide as far as I'm concerned, and allows us to understand the performance of many of these lenses. And this is from a talk from I think it was not David Chang, but from I think I forget the person who delivered this talk, but an excellent talk. And what you find over here is that the conventional Technis monofocal intraocular lens, which is, I think, a gold standard lens as far as the performance of the lens is concerned, because you find that it has there is a certain amount of degradation in the quality of vision when the pupils extend from 3 millimeters to 5 millimeters. All you see here is that what is in light grays and for a 3 millimeter pupil, what you see in dark grays for the scotopic pupil when the pupils dilate to about 5 millimeters. The sensor, you can find that the degradation is quite significant because it doesn't have the asphericity incorporated in it, while the Technis has the spherical aberration compensation that is over there. When you look at the Actisoft IQ, because of there is a certain amount of compensation for the spherical aberration, but the chromatic aberration is not completely addressed in these lenses. So what you find is that the performance of these lenses, as far as the MTF in scotopic conditions is concerned, is somewhat less. When you go over to the trifocal intraocular lenses, Even with this photopic condition, it's somewhat less compared to the monofocal intraocular lenses. And when the pupils dilate, the amount of degradation is significantly less. And as you can see over here, the multifocality in in the case of a trifocal lens is sub 0.2 in almost all the commonly used trifocal intraocular lenses. Come to the EDOF intraocular lens, essentially a symphony intraocular lens, you find that the photopic and the scotopic, the degradation when the pupils dilate from 3 to 5 millimeters is significantly very, very minimal. And you find that it's almost comparable to what you get with a monofocal intraocular lens. So essentially, you get something as far as intermediate vision is concerned, but there's no degradation of the quality vision compared to a monofocal intraocular lenses. And that has been the selling point for the EDOF Symphony for a long time. When you come to synergy, compared to the EDOF, there is a mild degradation. Instead of 0.44, it drops down to 0.34. In this particular chart, it shows as if in the mesopic conditions, it slightly improves, but that might be not true. But essentially, between the photopic, a 3 millimeter pupil and a 5 millimeter pupil, the synergy gives excellent quantity of vision without a commensurate drop in the quality of vision. I think that's the reason why we prefer these lenses. We all know about the importance of correcting spherical aberration. I think what we are doing today is also correct chromatic aberration with both the Symphony and the Synergy. And both these correction of the Q value of this almost the entire Technis platform lenses is minus 0.27, and the average Q value of a normal human cornea is about plus 0.27. They almost tend to compensate it completely, and also it has the ability to correct chromatic aberration because of the Abbe number and also because of the features which I'll be dealing with subsequently. And when you are correcting both the spherical aberration and the chromatic aberration, is not just additive, but they seem to work in synergy with each other, potentiate each other, and because of which the quality of vision when you get with any kind of Technis lens and with especially a Synergy is quite significantly higher. It more than compensate whatever degradation that would happen because of the multifocality that's incorporated in it. We all understand spherical aberration, but chromatic aberration is something which is still a new kid off the block, but we are beginning to understand it. We also realize that with the chromaline technology that is incorporated in the Symphony and the Synergy, we are able to reduce the chromatic aberration also significantly. What exactly is it? In all the normal human eye has a positive chromatic aberration. Because of that, the blue light is brought in front, focus in front, when the green light is exactly in focus on the fovea, and the red light is brought in focus behind. And this spread of focus can extend almost up to 1.38 diopters or thereabouts. But when you implant a conventional lens, which does not have a ability to compensate for chromatic aberration, that again comes with a positive chromatic aberration, because of which it increases the amount of chromatic aberration that's inherent in the cornea. And thus, once you implant these lenses, the amount of spread of this significantly enhances to almost 2 diopters, degrading the quality of vision. When you go ahead and implant a lens with the chromaline technology like the Symphony or Synergy, which comes with a minus chromatic aberration, it tends to compensate, not completely neutralize, but compensate for the inherent corneal chromatic aberration, and because of which the spread is considerably less compared to the other conventional lenses. And that's the reason that the quality of vision is much better. And especially added on to the spherical aberration that we already alluded to, it significantly enhances it. This is another way of depicting this. What you see in the dotted line is the kind of chromatic aberration that the patient would have subsequent if the patient was left aphakic. When you add on one of the trifocal lenses that are commonly used and that are quite popular, what you find is the chromatic aberration is significantly increased compared to an aphakic condition, simply because these all have a positive chromatic aberration. That's also the case with the Technis multifocal, though to a lesser extent, because it doesn't have a chromaline technology. But when you talk about the Technis Symphony or the Technis Synergy, because they have a negative chromatic aberration, they tend to reduce the amount of chromatic aberration compared to what would have the patient would have been dealt with if it had been less left aphakic, and that's obviously a significant advantage. The other important feature of the Synergy has been that it has a violet blocking technology. We all are aware of the UV blocking technology, where up to 400 microns is blocked off. Almost all intraocular lenses that are manufactured today have the UV blocking technology incorporated in them. The blue blocker, which has also been commonly in use, has been around for many years, blocks off up to 480 microns. That is, it blocks both, both the UV light as well as the blue light as well as the violet light. It has been found that it's the violet light, which is 400 to 440 nanometers, which is the shorter wavelengths of the light, which creates a significant amount of scatter and causes degradation of the quality of vision. But the blue light, which is between 440 to 480 nanometers, is important for the circadian rhythm, for scotopic vision, improves the quality of vision. When you block off the blue light, maybe there is a price to pay by way of compromise in the quality of vision. So if you can block off the more deleterious UV, the UV light and the violet light, but allow the blue light to pass through, that would be a significant advantage. And especially with the LED technology gaining ground in very rapidly, the blocking off the violet light becomes more and more important. And that's exactly what the Synergy is able to deliver. And that's one more advantage as far as these lenses is concerned. So essentially, just like the eye hands that Sataj talked about, there's really, if you're used to using the Technis intraocular lenses, then the Synergy is something, again, you can easily adapt. It has 15 rings on it, and it's a full diffractive lens. That's again a major value addition in these lenses, because of which the patient, irrespective of the lighting conditions, get the advantage of a near vision. And this is the intraocular lens, which has been implanted in the eye. It can go through a 2.2 millimeter incision, though my temporal clear corneal incision is usually 2.4 millimeters. You also see that the central disc is somewhat larger, because of which even in small pupils, the patients have a reasonably good visual acuity. So before, just like for any multifocal intraocular lenses, mind you, we are not saying that the Synergy doesn't have dysphotopsia. Definitely, this is a conversation that you need to talk to about your patients. And that's the reason there's a role for a lens like eye hands still in the marketplace. So there is splitting of light even with these lenses. So dysphotopsia enters into the conversation. Our preoperative evaluation and counseling is no different for these lenses compared to what we were doing with our earlier multifocal intraocular lenses. We do a comprehensive eye examination, use usually IOL Master 700. The LensStar also does a good job. There are several excellent other ocular biometers, but we used to, the go-to formula is not the Barrett Universal 2, but the Barrett TK toric formula, which tells us whether the patient requires a toric intraocular lens or not. If the patient has a significant toricity, even at T3 or a 1 or 1.25 diopters, especially if it's against the rule astigmatism, we completely sway away from the Synergy or the eye hand, simply because if you implant a multifocal lens, even a Synergy, without taking care of the cylinder, then that's not going to work too well. I think the Synergy toric is already available. The eye hands toric is also available, and we are looking forward to it becoming available in the Indian market also. And I'm told it's going to happen quite soon. So obviously that would increase the uptake of these lenses. Looking at the ocular surface, the OCT macula, the eye trace for extreme degrees of higher order aberrations is important. Angle alpha, we used to talk about it, but we do not give much importance to it. Looking at the higher order aberrations becomes especially important when a patient who has undergone prior refractive surgery, like a well-performed laser vision comes to you and looking for freedom from glasses. We were initially thinking that it's a strict no-no as far as implanting multifocal implants is in these conditions concerned. But today, we started implanting the Symphony earlier, and today, if the patient had excellent visual acuity, post-refractive surgery and had a small amount of refractive error corrected on his eye. And I find a sea of green on the topography with very little of high-road aberration, very little of coma at trefoil. With a significant conversation, I would not hesitate to go ahead and offer a synergy also in these cases. So what exactly is synergy bringing onto the table for us? There are several other excellent platforms. Is the freedom of choice that we have today to pick and choose the best lens that's suitable for each patient. So this gives us continuous range of vision from 33 centimeters to distant visual acuity for all lighting conditions, corrects spherical aberration, corrects chromatic aberration with potentiate each other, and that gives us a better contrast and quality of vision. Because it's a full 6 millimeter diffractive optics, it's a pupil independent design. There's a UV and violet blocking, and most importantly, it's based on the tried and tested Technis platform, which I think more than 1 million of these lenses, or is it 2 million? I forget, of these lenses have been used, and all the proven advantages the Technis platform is added on to the features that I already mentioned. I think this is so. I believe cataract is something just comes in. We are also using these lenses of prelex. I think you don't stop having fun when you get old, but you get old when you stop having fun. So 60, 70 is just a phase in your life, and you just have to go ahead, exchange your lenses, and enjoy life of a 20-year-old. So life begins at 60 centimeters, 60 at the age of 60, and maybe at 33 centimeters. So maybe synergy is a good choice to have. Thank you so much for your kind attention.
Thank you very much, Ram, for an excellent presentation and bringing out the finer points and the nuances of the new presbyopia correcting lenses. Just a question from the audience perspective. Supposing you're doing an IOL master and you're getting a reading, where would you want to keep this lens, on the first hyperopia or first myopia?
I think first hyperopia.
Yeah.
That's important. I mean, that's supposed to reduce improve the quality of vision and reduce the glare analysis.
Yeah, because the point is that the degradation in the quality of vision, as you have said, is much more if you are leaving the patient myopic as compared to the first hyperopia. So if your IOL master is giving you a plus 0.12 or a plus 0.27, you'll err towards that rather than going to a minus 0.27 or a 2 point for that. Sataj, you have any comments?
Just to make it clear to the listeners, what Dr. Maipal is trying to bring about is, our tendency has always been to drop a little bit of vision for reading as we talk about micromonovision. So if we get a 21.3 as your intraocular lens power calculation, usually we'll go ahead and implant a 21.5 because you want a little bit of add for near vision. But here, what we would go ahead and implant is at 21.
Yeah, and the other advantage that is there, what you actually rightly pointed out, is the 33 centimeters. So this is something that actually gives good reading. You don't have to push yourself behind for getting. The other advantage, obviously, in this sense is the marriage, I would say, between a EDOF and a trifocality to increase the range of vision, and that's why they've called it as a continuous range of vision. Sartaj, have you a lot of experience with these CRV lenses?
Yes, not a lot, a fair amount. And it's very good, definitely. I have patients as far as near intermediate vision is concerned. They are very, very happy. In fact, we implanted it bilaterally in a orthopedic surgeon, and he was very happy. He was able to operate comfortably without any glasses, even fine screws, no problem. But coming back to the same thing, that it's just not fair to offer these lenses without the toric correction immediately available. So he says, I mean, he's operating, he's very happy, but when he's on the golf course, he looks at the flag on the golf hole, and he can have a little bit of shadowing on that. So if we can correct that astigmatism a little better, I think these will be the go-to lenses. They are excellent.
Okay. From a perspective, Ram, I know that you have a lot of experience of the trifocals or the presbyopia correcting lenses. From a clinical setting perspective, which is a lens that you will maybe get implanted in your eye and maybe in your enemy's eye?
Really. I mean, I think, frankly, we are talking about synergy, but there are excellent trifocal lenses that are also available to us. And one of the, as we all have emphasized, one of the advantages we have with the trifocals in India is that they are available in the toric platform. And when you are implanting these lenses, even at 0.75 diopters of astigmatism, you need to deal with that, especially if it's against the rule. And that's the reason that those lenses are being used in good numbers. And the Synergy is a great lens if there's hardly any cylinder on the cornea. And that's to my go-to lens when pure spherical lens is needed and the patient is interested in multifocality. I think the trifocals also work very well. But the main advantage is that when they talk about near vision and trifocals, it most often begins from 40 centimeters. And while in Synergy, I think even a little closer, small built individuals, whether it's Tamil or Hindi, our letters are much more closer compared to the English alphabets. And the ability to read better with this lens is an advantage. And maybe as of now, if I find that I don't have significant corneal cylinder, I don't have much on my glasses, if I had to get my cataract surgery done, then I would go for a Synergy.
Okay, let me be more specific in real life situations. What is it that has stood out? Say you've done 60 of these eyes, the data that you presented. So what exactly is a wow factor or anything that Synergy is offering over the previously used lenses, maybe a Panoptics or a Zeiss trifocal or an Indian triphobic or whatever it is? Is there a specific wow factor or anything that you feel that the patient has really come out and said or not said as regards the after post implantation?
One is, as I already mentioned, is the better near vision. Almost none of them require glasses, almost none of them. I mean, so somebody does say that a little difficulty in reading a scriptures for a long time or something like that. But then I don't remember prescribing any glasses to any of these patients. There's no micro monovision or monovision or Blixen mask that we are doing. We're almost aiming at emmetropia bilaterally. And once we hit that sweet spot, then these lenses work quite well. And though we never tell them that dysphotopsia is not a factor, and it's not that it's a controlled study that we have done, but in my experience, I have seen hardly any of these patients coming with a significant complaint of dysphotopsia. We still continue to warn these patients that because of the splitting of light, you could have glare and halos. We even have pictures showing that preoperatively. But the good news is that postoperatively, you're hardly spending any time telling them that you'll get used to it. Over time, you will adapt to it. I would continue to warn these patients about dysphotopsia, but anecdotally, I can say, I think I find that the incidence of dysphotopsia is much less. And also the fact that it's a crystal clear lens that you have over there. And once you have implanted in the eye and the surgery has gone off well, it's nice to see these eyes well centered in the capsular bag. It gives you a thrill.
Okay. Sataj, any comments or any question?
Yeah, I think coming back to what you just said, that, the wow factor for the patient, a satisfied patient post-operatively is probably one who just, asks fewer questions or makes fewer statements that he's just like, I'm very happy, no complaints, end of discussion. With the trifocals, although they're excellent and we've been using them, dysphotopsia is a lot less, but a fair number of patients would notice that sweet spot phenomena, that it's very clear over here, and then, a little ahead or behind, it's not as clear. And you would continuously be trying to explain that muscle memory will build up over time. With these lenses, I do feel that is less. And that is essentially, the primary purpose that these continuous range of vision lenses are trying to establish. So I think over there, at least from my initial experience, they do seem to be succeeding. So a patient who would have a trifocal in the other eye and would maybe compare, they would be able to appreciate that. But for most patients, just the fact that they're not observing that sweet spot phenomena to the same extent, I think that is a win-win situation in itself.
Okay, great. Ram, any comments? Or
no, I think you should go on to your talk, Maipal, and maybe if we have time, we can take more questions later. I think it's my pleasure to introduce my chairman, Dr. Maipal Singh Sachdev. Apart from other things, he has always been one to adapt to new technology. as soon as it becomes available, and has been a trendsetter as far as Indian ophthalmology is concerned. It has been no different as far as femtosecond cataract is concerned. And I find nobody who could be better than him to take us through how femtosecond laser has enhanced his cataract practice. Over to you, Mehta.
Ram, host, please allow me to share my screen. AV, you have disabled my screen sharing. Can you allow me to share? Okay, thank you.
Sir.
Yeah, thank you. Okay. I'll be talking about the difficult situations that femtosecond laser assisted cataract actually helps us in. And thank you, Ram, for the kind words. Just in the previous session that was there from the morning, Steve Arshino was telling that the comparison that has happened between the utility or the advantages of flax has been over routine grade 2, grade 3 cataracts, and not specifically in situations where there are difficult kind of situations to handle. And what he has shown is that as you move up the scale of difficulty, or the scale where there is a difference in the normal cataract versus what you are going to handle, that is where the femtosecond laser assisted cataract surgery actually brings in a lot of advantages. I am a consultant for J&J, but I have no financial disclosure for this particular presentation that I am going to make. So femto, I would say, is a tool for the routine, but it is a much greater tool for the challenging situations. And that is where we want to work, is to simplify the complex. So this is what I'm going to, my talk is going to be, and not for the routine as to what a femto is, how it does, because today, at least in my personal practice, about 70% of my cataract procedures are done through the femto laser assisted cataract surgery. And mind you, as things grow, I think this is reaching an inflection point, at least in this part of the country, specifically in Delhi, where people are now actually very, very comfortable getting a femto laser assisted cataract surgery done. And Haryana government has even allowed it for their, they are reimbursing them for the patients who want femto laser assisted cataract surgery. So let me talk about my first difficult situation, and that is the posterior polar cataract. As we all know, again, in the last session, we were talking about the incidence of PCR in posterior polar cataracts when it was first described by Bob Osher was pretty high to the extent of about 30% typical onion bulb, this thing, appearance that you can see. But with the advent of knowing more about hydrodissection, hydrodelineation as to how to look at a posterior polar cataract, and the advent of femto laser assisted cataract surgery, we are now getting less and less troubles and problems while dealing with a posterior polar cataract. Now, when we are looking at a posterior capsule in a posterior polar cataract, there is the pre-existing weakness in the posterior capsule, which is there, and cortical cleaving hydrodissection can cause a hydraulic rupture of the posterior capsule, which makes it a problem. You could have nucleus drops, etc. That is there. Now, when you are looking at the femto laser assisted platform, it actually helps you do a pneumo delineation, and this pneumo delineation is actually not going and disturbing the epinucleus, etc. It eliminates the need of hydrodissection and hydrodelineation with fluid, and it also helps you in getting a fantastic capsulorhexis, which can be used later on for a support. The nuclear disassembly has already happened, and because the nuclear disassembly has happened, the amount of manipulation that you have to do to remove the nuclear fragments is much, much less. Concentric rings or segments can be done to simplify nucleus removal. Now, the first thing that I'll be talking about is the advantage of visualization. And as we all know that in any femto laser assisted cataract surgery, there is the anterior segment OCT, which is a high definition 360-degree OCT that we have. And this delineates the anterior and posterior corneal and lens border. So you can see this is the corneal border that you have. This is the anterior capsule. And you can see here that this is the posterior capsule that it has delineated. And what is very, very clear is that instead of the capsule being continuous here, you are actually having a bump which has gone up in this particular case. So you are pretty sure that this is going to have a pre-existing capsular rent in this particular case. And mind you that this is very, very specific in finding out the pre-existing posterior capsular defect. Now, the obvious advantage here is that the offsets, which I'll be just showing you, can be customized so that you are leaving behind an epinuclear cushion, which is very, very important for a safety cushion till the end of the surgery, which is there. So let us just go and see. So this is the offset. You can see that these are the three bubbles that we have, and we are raising these three bubbles. And once we raise these three bubbles, what I want to show you here is that this is the portion where the nuclear disassembly is going to happen. And you can see here that this is the area of discontinuity. So I have been able to leave behind an epinuclear cushion, which is giving us a great comfort till the end of the surgery that the posterior capsule will not give way. So this is the customizable offsets that one is able to do in these particular cases. We have published this paper in the Journal of Cataract and Refractive Surgery, where we have been able to conclude that a femtosecond laser with integrated ASOCT is a relevant and helpful tool to detect and increase the safety in pre-existing posterior capsular dehiscence, and it is alerting the surgeon ahead of the phacoemulsification that there is a pre-existing defect which is there in a polar cataract or not. And it is, mind you, and on the table that after the femto has been done, that I tell my anesthetist that whether I need to do this patient under peribulbar block, I'll just continue to do it under topical, because there is or there isn't a pre-existing posterior capsular defect. So let us just see in this particular case. This is an image on slit lamp. So there couldn't be anything better than this image that you get on the slit lamp, where you're seeing that there's a posterior polar cataract, and you can see a typical pre-existing defect which is there in this particular case. And I'll just show you how the OCT and everything helps us work on this. So this is another slit lamp picture that you can see. So we are doing a femtolaser procedure in this particular case. Again, you can see that this is a huge defect which is here, which you can see, and you can see that how the capsule is coming down, and there is a defect here. And then we have the bubbles which are seen here. We will just increase the default setting. That means that I am going to leave a bigger epinuclear cushion, and I am making it into 6 quadrants, and I'm doing a good capsulotomy. So this is the capsulotomy that has been completed. You can see in this particular case, this is just before I start the phacoemulsification procedure. So mind you, let's see, 1, 2, 3, 4, 5, 6 quadrants which are there. You've got a beautiful capsular axis. You can see it's almost a free floating capsular axis. And you can see that this is the defect which I showed you on the slit lamp as to when it is there on the under the surgical microscope which is there. So look here, we are using an intra-op OCT. You can see that this is the defect which is very clearly seen on the intra-op OCT. I have done no hydrodissection, no hydrodelineation, and I have been able to remove the nucleus, and you can see that the epinuclear cushion and the danger area of the posterior polar cataract is pretty much there. So we can go ahead with a bimanual IA, but I'm so very used to coaxial that you can see, and you put viscoelastic before you remove, and you can see this is vitreous bulging out in this pre-existing rent, and you can go ahead and implant an intraocular lens and get away with good results. And this is the post-op picture that you have. Now, this is the posterior capsular imaging of a posterior polar. This is the images that I have shown you. The important thing here is that it is also visible on the IOL master. We are just about to have the results out for comparing on a pentacam, on an IOL master, and on an anterior segment OCT and an intra-op OCT as to the specificity and the sensitivity of the diagnosis of pre-existing posterior capsular rent. But in this particular case, you can see that there is a pre-existing posterior capsular rent. You could see it on the OCT. You can see it on the slit lamp. This is the integrated microscope, which is, you can see the epinucleus still there in this case. Once the cortex has been cleaned out, and you can see the vitreous bulging out, which is there. So the epinucleus provides you a great shield, and the femto provides you precise, sharp, but smooth pneumodissection that is there. Posterior limit of nucleotomy of 100 microns. From 500, you can increase to 1000, 1200, or whatever is required on direct visualization. And the thick epinuclear layer acts as a shield for the weak posterior capsule from the mechanical and turbulent forces that are there during the phacoemulsification procedure. Nuclear rotation can be done because there is a pneumodissection that has happened, and you can rotate the nucleus without disturbing the posterior capsule, which is there. So you are actually looking at a safety bag, which is not there for your crash that you can have. But if you have this airbag as a safety, you will go out unharmed in a posterior polar cataract. So Flax offers you this safety bag that is there. Now, femtosecond laser is contraindicated or cannot possibly be done in small pupil, or it cannot be done when there is a significant amount of corneal opacity, because the laser, anything that blocks the laser beam, whether it be an opacity or a pupil, is going to have problems. So you can go ahead and put a Malugin ring and go, do the surgery. After washing the viscoelastic, you can use the same setting. But if you have visco in it, then under those circumstances, you have to actually increase the power setting. So see here, this is a Malugin ring that is being implanted, overlay of the Varion. And once this Malugin ring has been implanted, you can go ahead and see here on the, there's a subluxation. You can see in this particular case, the iris was going down, and this is the femto procedure that is being done. And once you have done the femto procedure, the advantages of this will be that you have a great capsular excess, you have a nuclear disassembly, and you have the Malugin ring in position, and you can go ahead and do the surgery. Now, this is a white cataract that you have, an intumescent cataract, and again, again a go-to for my cases. Whenever I have an intumescent cataract, I tell the patients that whether you can look at it as a procedure of choice. So you can see that the iris is very close to the back of the cornea. You could see the intumescence, you can see the huge lens, and the biggest advantage in these particular cases is that you are working on a capsulotomy on a closed chamber. And again, always use trypan blue, because you could have areas of skip that you can have in these particular cases, and you can go ahead and remove the cataract pretty well. Even though if you are having a white cataract, the nucleotomy may not be great, but a fantastic capsular excess is what you require in these intumescent cataracts. In rock hard black cataract, this patient was being considered for a SICS, but then I said that, okay, let us try a femto laser. The advantages of reduction in the phaco energy is significant in hard cataracts. And you can see, can you see this? These are the bubbles that are coming out, and there is a pre-chopped black cataract that you have in these particular cases. So mind you, as long as the laser beam can penetrate, or you can focus, the laser beam can focus, there will be cuts that will come into the nucleus. And with the new software of the Catalyst system, which is there, you can actually just leave the central 1 millimeter of the nucleus, because that will crack, and the time of or the quantum of energy that is being released has been significantly decreased. Now, this is a post-traumatic subluxation, again a difficult cases. So whether you have pseudo exfoliation, loose zonules, or you have already loss of zonules, which is in a post-traumatic subluxation, I would go to a femto laser assisted cataract surgery in these particular cases. So you can see that this is a subluxation in a doctor who came from Bihar, had an injury, and you can see that these are the zonules that are missing in this particular case. And we have just published this article, which is in the IGO, the role of limited pars plana vitrectomy for optimizing surgical outcomes in subluxated cataracts undergoing femtolaser assisted cataract surgery. And in these particular cases, what we use is a pars plana vitrectomy that is done beforehand after the femtolaser assisted cataract femtolaser procedure. That helps us in decompressing. It helps us in reducing the vitreous coming out more and increasing the dialysis. So let us just go ahead and see this particular case. Now, please watch this particular side where we showed you the subluxation. You can see that the iris is going down. And if you look at it minutely, you can see that there is a blob of vitreous, which is right here, as can be seen in this particular case. So let's go ahead. Again, we have to match the anterior and the posterior capsule. We are doing a custom centration because the scanned capsule was different. This is the capsulotomy that has been done, and we are preparing for the pars plana. So you can see there is fluid that is coming out. So we go ahead and do a limited vitrectomy. There is tricot that has been used, and you can see that the vitreous is coming out, but we are getting a good capsular excess. I'm putting an endocapsular ring because there is a huge subluxation. The beautiful disassembly that has happened is going to allow me to work on lower settings and lower parameters in this case without doing any significant maneuvering or rotation, etc. Switching on to a bimanual procedure, you can see that there is the bag is reasonably stable even though there is movement, and you have to do a tangential separation of the cortex in these particular cases, and we supplement ourselves with a 3-piece lens despite the CTR to get a good outcome in these particular cases. And this is the post-op post-traumatic subluxation case that you have. So friends, I would just wish to say that it is really the complex femto cases that helps us, complex cataract cases that helps maximize the potential of femtolaser technology. And obviously, if you look at routine cataracts, one may try to say that the outcomes could be pretty similar, but in these complex cases, it definitely makes the outcome much better. One thing is precision, accuracy, repeatability, and the skill set of an individual may not be that high even to get out after a post-femto laser. So that's something that has eased out the surgery. Obviously, when we started with femto laser assisted cataract surgery, the price points were very high of the differential. And I think that was, again, every country is price sensitive, and India more so. We were not able to do a penetration of the femto laser, and we would be struggling at 10 to 20 to 25 femto lasers a month. But with the prices having become more rationalized and the differential or the delta not being more than 100% that we used to have before, I would say we had 120 or 130% delta between the normal cataract surgery and the add-on of the femto. I would say that today femto is a go-to procedure. And with the numbers increasing, we have seen across, at least in North India, that the patients are lapping up the femto laser assisted cataract surgery. I don't know, Dr. Ram and Sartaj could also chip in to say as to how their numbers are growing over the years. But I think the hesitancy that one has in investing in a femto laser because of its cost is going down. Repeatability, being able to do it, I didn't show, but we have even in blebs, you can see the blebs very well and do that pseudo exfoliation, Marfan. There's lots and lots of ways that we can go ahead and do it. The only thing is, in very dense corneal opacities, obviously, I have to say no to these particular patients. And sometimes because the cones are, we have only 2 sizes, once you have very small nanophthalmic eyes, at times doing a suction, getting a good hold on these eyes becomes a little difficult. But otherwise, I think the technology has changed very significantly. They are working now on the LRIs with the new COS6. In which cyclotorsion is automatically getting compensated, and the only thing is that it is just now aligned with not aligned with the present topographers that we have on us, and it's aligned only with the Cassini, where the OPD steep axis will get aligned to the femto on the table. So that once we have that with the Pentacam or with the Cirrus, which is more often than not available with us, I think that's going to be an additional advantage that for small astigmatisms, one could go at LRI. Just now, not everybody is very fond of the LRIs because of the slight I would say, less predictable results as regards the LRI as compared to a lens-based toric intraocular lens implantation. So I would say, friends, it's the time to take the leap of faith and switch over to the power of femto as the new tool. I know that whenever a new technology comes in, there are more critics, and there are people who have to do the path breaking and look at bringing out the advantages of a particular technique. And I think that's when you hit the inflection point. And I am feeling that the inflection point in femto laser is happening in at least in North India as things stand today. Thank you very much for your kind attention.
Excellent, comprehensive talk, Maipal. Covered almost everything as far as complex situations are concerned. You first, Sataj, any comments?
Yes, sir. So I completely echo excellent talk, sir, and your points are very relevant. Uptake is increasing. I think one of the most significant factors is most ophthalmologists who are going in for cataract surgery are choosing Femtosecond for their own surgeries. I think that alone speaks for the procedure itself. The situations you highlighted were excellent. Maybe one thing I would add is pediatric cataracts, because in that, the most challenging part, again, similar to intermittent cataracts, tends to be the capsulorhexis, both anterior posterior, where again, with femto, you can achieve that perfectly. One thing that you mentioned, sir, for cone preference, for general cases, do you have a default preference for the larger cone or the smaller cone?
So actually, it's a little easier to hold on the smaller cone, but by far, I started with the black one, that's the larger one, and continue with the black. If the eye is small, if the aperture is, if the palpebral aperture is causing me problem, then I go on with the smaller one. So I think it's about 60-40 or 70-30 that the larger cones I use in about 70. But there are people who just go ahead and use the smaller cone because it gives you an adequate show of the limbus in either case. The other big advantage that we have in these is that I don't get any cherry red spots against a hard dock that used to happen earlier, which is now with the soft fit become softer, but still you don't get any cherry red spots in these particular cases, and the eye look pretty clean the next day. So yes, 60-40, 70-30, I use the larger size of the PI, LOI.
There's another question that I'd have is the excellent subluxator cataract case that you showed, and using pars plana vitrectomy later on to soften the globe and get that vitreous out of there. What if there's a significant amount of vitreous in the AC prior to starting the surgery? How would you handle that?
Okay, so I showed you that there was vitreous. The thing is that is the biggest advantage until, of course, the subluxation is very gross that you are not able to get a focus, because see, that's what you have to realign the anterior capsule. So that's this machine gives you the flexibility of realigning either the anterior or the posterior capsule. So you have to have the three bubbles aligning on to the anterior capsule for you to get a capsulotomy. The vitreous per se does not pose any challenge for the laser to go through it. And that is the biggest advantage, that the counter traction force that you need for doing a needle rexes or you want to do with a Neutratas is really not a challenge. And there is no way, I haven't gone in and done a vitrectomy and then got the patient, because I have not had a challenge in getting the laser penetrate through any small vitreous which is there. And normally when you have the vitreous also, there is one thing to remember, that it does not come and cover towards the center of the capsulotomy area, which is 5. My normal default is 5. For hard cataracts, I keep it at 5.2 because there is a stretch and the capsulotomy tends to increase by about 0.5. But obviously what you are trying to say is that if there's lots and lots of vitreous in the anterior chamber coming right into the center, what would you do? I would still want to not hamper the globe and still go ahead and maybe increase the energy settings if required a little bit. But I've never played with my energy with the small amounts of vitreous in the anterior chamber.
I think just a few comments, almost everything was said. Maipal mentioned about the utilization of this technology as far as small pupil is concerned. I personally would not like to put in some kind of expander device and then take the patient back to laser, because as we all know, the laser procedure as such is semi-sterile or an unsterile procedure. So having a opening into the anterior chamber and then redocking. Though that's done with a sterile cone, there is a risk, but then I am aware that several surgeons do that. More importantly, of course, the extremely small pupils like 2.5 millimeters, maybe I'd stay away from a laser technology. But we are more often faced with situations where the pupil is about 4.5, 5 millimeters. And what we have to understand is that in Catalyst, the default setting, and most often we go with the capsule-oriented capsulotomy, and there is a distance of about 0.5 millimeters from the rim of the pupil. So when you have a 4.5 millimeter pupil, you will get if you just go with the normal capsule-guided capsulotomy, you would get a 3.5 millimeter capsular excess, which is not quite sufficient. In these cases, there is a ability to go ahead and do a pupil-centered capsulotomy, where you can manually adjust it so that you come as close to about 0.1 millimeters from the pupillary margin. And you can also check this out both on the sagittal and the axial view and make sure that you are away from the pupillary margin. At the same time, you are going maximizing the amount of rhexis that you are getting. With this, my limit as far as small pupils is concerned is about 4.3, 4.4 millimeters, where I end up with a 4.2 millimeters. Another thing, as Maipal said, when we are doing it manually, we are all aiming at a 5.5 millimeter rhexis. But when you do with a laser, you do a 5 millimeter rhexis simply because you find that it retracts a little bit. And so you end up getting a reasonably good rhexis for most cataracts to deal with. Other factor, of course, the intumescent cataracts, it's for great help. Sometimes I just switch off everything else. I don't make incisions. I don't even some of it becomes a challenge for the laser to recognize the posterior limit. But just getting an accurate capsulotomy, well-centered 5 millimeter capsulotomy is worth the laser. And just using it for that itself is good. But even in these cases, I would always stain the capsules, because even though you have a free-floating rhexis quite often, because there are sometimes tags which are not visualized unless you stain it and go through a side port with a bent cystitome and try to separate out the capsulotomy as you would normally do. Because if there are tags and you pull on the rhexis, sometimes you could have a rhexis run off to the periphery. So it's always a good idea to be cautious, though it works out most often. Another factor is the speed of the capsular rhexis that the catalyst creates. It's able to create in a 1 to 1.6 millimeter, 1 to 1.6 seconds, because of which the surge of fluid that you get, even the small time it takes, the chance of getting a disrupted capsule is much less. But there have been occasions when in this platform, when in extremely intumescent cataracts, I have had a disrupted capsule and you could deal with it. And apart from the intumescent cataract, there is also fibrosed capsules where it may not give you a free-floating rhexis, but it gives you an excellent template. It gives you around 5 millimeter rhexis, and then you might have to use your conventional capsulotomy maneuvers with a needle or the utrata forceps to complete the rhexis, and gives you a great capsulotomy. And though it doesn't penetrate through white cataracts, as far as brown nuclear cataracts, as Maipal pointed out, laser is nothing but light. And if light can go in, it creates, divides the nucleus. And whether it's a softening or segmentation, most often you find that even in hard brown cataracts, you are able to get the segmentation and nucleus almost up to 500 to 800 microns away. Posterior polar cataract, I think, was very nicely covered by Maipal. I hardly have anything to add to it. And apart from ASOCT, you have it online in this and you are going to use it. Limbal relaxing incision, needless to say, when there is significant amount of toricity, it is something that going for a toric intraocular lens is the right way to go. But then the ability to exactly locate your incision where you want it, even if it's against the rule astigmatism, what most of these patients have, I go ahead with a paired limbal relaxing incision at the 0 and 80 degrees axis at 8 millimeters. I still go ahead and create an incision, avoiding the arcuate keratotomy that has been created. And I find that it works quite well. And I always open up these incisions, leaving behind a intrastomal arcuate keratotomy doesn't seem to have a significant impact. So yes, it's not refractive accuracy like what you would achieve with toric intraocular lenses. But when you have a 0.5, 0.75 diopters of astigmatism, the ability to debulk the astigmatism to a maximal extent, especially if you're putting in a multifocal intraocular lens, is a significant advantage when you use these laser platform. I think otherwise almost everything is
I'll just, thank you very much for your great insights. There are 2 points that actually just came to my mind that you'll be talking about. There's the news software that you have, which also helps you in the alignment marks for the toric intraocular lenses. Sorry, it just slipped out of my mind. I could have shown that. But if you have the new software in that particular case, and you have the alignment and cyclotorsion error that has been compensated on the Cassini, you will get 2 radial marks. And these radial marks would exist post-operatively also. So you actually, in the post-operative period, you can also see whether the alignment of the toric intraocular lens is proper or not. And wherever the lens has to be placed, you can actually mark it on the cornea. And you can shift as to where you want to mark that on the cornea, whether you want it at 8 millimeters, 7 millimeters, or 8.5, whatever you want. So that is an additional advantage that is there, because Lens AR also came with a system where they make the capsulotomy slightly discontinuous. So there are knuckles which remain on the capsulotomy at the axis where the lens has to be aligned, or you can make it 0-180 so that in the post-op period also you can go ahead and see whether there is any rotation of the toric intraocular lens that is there or not. And the second point that I wanted to stress or highlight what Ram said was about the pupil. So there are, so you can have the capsulotomy centered on the capsular scan. That means that whatever is the scanning of the capsule, whatever is the center of the capsular scan, that's the default setting that we normally keep. You can have it centered on the limbus. You can have it centered on the pupil, and you can customize it. So in the customization, what you can do is that you can move if you have an irregular pupil or whatever it is, you can move the capsulotomy as I showed in the subluxation. So in case we are expecting a CTR or something to move away the present position of the rexis to a different position after you have a segment or a ring that has been put in. So you would want to displace it so that you can actually have the capsulotomy become centered later. And the default setting, as Ram said, on each side 0.5 millimeters, so 1 millimeter smaller rexis that comes in, and you will have to actually fool the machine by making the pupil a little larger than what actually it is, so that you can actually make the capsulotomy almost kiss the border of the iris. Important thing is that we do not have, because it's not a hard dock, so the pupil coming down on you and the amount of energy that is being used is less. So the pupil does not come down to that extent post-flax in a catalyst system, and it's a liquid optic interface. So you don't have posterior corneal folds, and that is the reason why the capsulotomy is almost free floating in all the particular cases that you have. But putting drops of NSAID is important when you are doing a femtolaser assisted cataract surgery. As soon as my femtolaser procedure is over, we ask the attendant to put a drop of Tropicacil Plus to keep the pupil dilated in our cases. So those are a couple of practical things that I just wanted to bring out.
Excellent points, Maipal. I mean, that's exactly what we do also. When you have a series of femtocataracts, we go ahead and do the cases continuously, and then while the patients are waiting, a drop of NSAID as well as a dilating drops is put in. And we find that the pupils do not really come down compared to what you saw during your laser docking and what you see on the table. Usually it remains. And the other point is, as you mentioned, with the recent software upgrade that has come with the Catalyst, both for the size and the position of the arcuates as well as the position of the toric intraocular lenses, I think it's inbuilt in it now. The only problem is it works well with the Cassini. And as you pointed out, I think Cassini has not been a very popular topographer in our practices. Maybe it will pick up over time. But once you have that Cassini, and is something I think the utilization of these aspects will further increase.
And another point is, I don't know, Sartaj, how you do, or Ram, how you do, but I think if you have a team, you are actually cutting down on the surgical time, because there was a lot of it that was said about surgical time, because you don't need to be doing both these steps. So there could be somebody who could be cutting outside and somebody who could be doing the inside procedure. That's the advantage of a team. And the surgical procedure time has actually gone down by 2-3 minutes inside the OR. And if there is somebody else outside, so the actual time you are blocking the table has gone down in the OR. So it's not that it's more time consuming and things like that. And as you move, I think the laser per se works less than a minute. It's 30 seconds, 40 seconds or something, depending upon how big your nucleus is and how many segmentation, etc. The other thing that we have worked upon is, I think most of us would agree, that we are not making the softening into much smaller cubes or pieces, because at times with the lateral movement of the ellipse or the nozzle, etc., you could actually, the incidence of retained small nuclear fragment actually went up post once we were making these the softening and the quadrants, the segments to be about 100-200 microns. So I normally make very big, or I make 6 parts to the nucleus, because that helps you give a better purchase on the phaco tip, rather than having these cheesy things coming out. So that is another thing that we have changed over time. And the amount of energy is definitely reduced to almost 50% or 60% less required, more specifically in the harder cataracts when you have a pre-chopped nucleus. Okay, so any final comments? I think we are at the end of the new technologies that are available in cataract surgery, obviously not covering everything. But Ram or Sartaj, any final comments? Otherwise, we can wrap up.
Well, I think, both these technologies that we discussed are complementary to each other. One is about the extraction of the cataract, another is about the replacement of the lens. So when you have high-end technologies, that both of them work together to lead to more satisfied patients. As was mentioned, we find that patients opting for these high-end intraocular lenses also offer a laser technology, and both these work in tandem with each other, raising the satisfaction levels. I think it's good to have these multiple options and constant progression. I still do not feel that we have reached the zenith of what can happen, and maybe interesting times ahead. And over time, in our own professional lifetime, we might see even better technologies coming from.
Great. Sartaj?
Completely echo what Dr. Ramamurthy just said, that these are complementary technologies. I think the best part about plaques is sort of the democratization of skill, that it's again improving the standard of care for cataract surgery, that anybody with that machine can get the same size capsulotomy, the same nuclear fragmentation every time. It's that consistency of care, so that safety advantage for the patient, complemented with these better IOL technologies that are available. And again, we will continuously see progress in this field thanks to the research that is done in the background, and these companies that are continuously working to get us better technology. So the future holds a lot of promise, but I think already the consistency of elective procedures such as cataract are incredible. And it's great to see that our patients are very satisfied these days.
Yeah, so thank you, everyone. I'd wish to thank the panelists, co-chairman Ram and AIOS and J&J for this session. But suffice to say that at least in our lifetime, Ram and myself, we have seen cataract surgery really change. And I still remember going to the camps and doing a cataract knife incision and doing a cryo. That cryo, when it came, it was a big thing. Otherwise, you would do a Smith Indian technique and you could have vitreous coming out in 10% cases or maybe things. So things have really changed from where it was in the microsurgery. I think the leaps and bounds, because cataract is the commonest surgery that's performed on any part of the body, and that's where the advances have really helped restore the quality and quantity both. Earlier it was all quantity, but now we are talking about quality and spectacle independence and perfect results. And the kind of results that you get post cataract surgery are really gratifying. And with these new technologies, the incidence of having unforeseen complications, etc., has really gone down. So thank you very much, both Dr. Ramamurthy and Sartaj, and God bless Sartaj, doing a great work, and wish you all the very best.
Thank you.
And AIOC and J&J and also the audiovisual team of Ravi Grover and our moderator Hime for being with us. Thank you very much, and have a great day ahead. Thanks.
Thank you.
Thank you.
Bye.